So where are we right now in 2018? This is the way I look at it. TAVR's pretty good, right? We've taken the guesswork out of imaging, predictable deployment, the techniques, a little caudal here or there, high deployment, pretty refined. It's pretty rare that something really bad happens. Stroke seems to be getting better with cerebral protection, but even without it. And bad perivalvular leak seems pretty much under control too, with the exception of maybe some rare subtypes. So what's left, or where do I think we can optimize TAVR in 2018? These are the things that I think we ought to think about. The invasiveness of the procedure, certain subtypes, and patient prosthesis mismatch for valve-in-valve. So let's start with invasiveness. When I was learning to do TAVR in 2012, putting everyone to sleep, TEEs, mandated cut-downs to the groin by Edwards, my new partner, Vasilis, already had this thing down to a calf. And so the goal with this minimalist TAVR thing is make it simple and at least maintain, but possibly actually improve outcomes. And of course, reduce cost. Now, everybody here knows who's probably a good candidate for a straightforward minimalist TAVR, right? Think about it, There wouldn't be a hard intubation. They can cooperate with you. They're likely to get up and move around. So there's already described algorithms for this. And certainly it's going to save you money, right? Because you're eliminating half the stuff that you do during the procedure. But more importantly, the outcomes are certainly no worse. They may not have proven yet to be better, but certainly no worse. But actually, as time gone on, in 2017, Vasilis looked at their 1,000 patients with this approach, and as the newer generation valves come out, outcomes are getting better and better. So the way I look at it, it wouldn't be hard to think that outcomes may actually get better by doing less. Same thing with discharging them on the next day. Doesn't appear to be, when you look at the data, that outcomes are any worse. So for optimizing TAVR, number one, nothing good happens to anybody in the hospital. That's what I always say. So stop the intubation, stop the general anesthesia. Don't put a 9-French, 12-French sheath in the neck. We don't do A-lines anymore, no bladder catheters, no ICU. Get them out of bed and get them home the next day. Number two, what about the people who you can't do a standard transfemoral? Used to be TA and TAO sort of ruled the world. But every paper shows that outcomes appear to be worse. In the real world, if you propensity match these people, and actually you can't even show that alternative intrathoracic access is actually better than full surgery. There's been no data to actually show that yet. So on the other hand, if you push the transfemoral for people who don't have good access, bad things happen also. So of course there's this cadre of alternative access for those with poor vessels. Well, let's look at some of these. There's good data now, 200 patients from the CoreValve registry. Surgical subclavian looks pretty similar to transfemoral outcomes. We did a 100-patient study with transcaval access, bleeding almost the same as standard transfemoral. We looked at our own carotid access, did just as well as our own transfemorals. And actually, one of my new partners, Dr. Deveretti's, now started using the shockwave lithotripsy balloon to actually improve delivery of standard transfemoral access for people that you wouldn't normally get the catheter up. Things have moved to percutaneous transaxillary, less data, but certainly been shown feasible as an alternative as well. So number two, you want to optimize TAVR in 2018. If you have poor iliofemoral anatomy, pick one of these, but get out of the chest. How about the coronary obstruction risk? It is rare, but if you think about how many times you put a wire down just in case, it certainly can happen. There's certain predisposing factors. And even though it's rare, the fact of the matter is it's pretty bad outcomes if it happens. Even if you get the vessels open, these people all go into shock, and despite a high PCI success rate, forget it if you're not successful, they all die. But even if you're successful, there's a high mortality rate. And it's complicated knowing who's going to obstruct and who's not going to obstruct. The conventional way to do this, by putting a stent down and then deploying it if necessary, may be simple, but it's not very elegant because it's aspirin and Plavix for life. Sometimes you can't get the stent out. You have to chimney it a long way. And sometimes the occlusion occurs late. So third point, innovation for optimizing TAVR. For those of you who don't know Basilica, this is a novel transcatheter technique to minimize the risk of coronary obstruction, developed by Jaffer Khan and Robert Letterman at the NIH, where we modified Lampoon, which we were doing for mitral valves, to now split the leaflet of the indwelling by a prosthetic valve or the native valve to get the leaflets out of the way. Dr. Mack will tell you, right? They take out the whole valve. They don't have this problem. But we can do something similar to get the leaflets out of the way to prevent coronary obstruction. Here's a case that I did early on, a mitral flow that clearly would have obstructed. You can see that leaflet in the way. Here's what it looks like angiographically. Burn through the leaflet. Echocardiographically, you can see the bubbles and the burn through the left leaflet. Create the lasso and slice the leaflet. Here's what the split leaflet looks like. You've made it a quadricusp leaflet. Do you see it right in front of the left main? There's a beautiful split leaflet still working. And here, after valve deployment, no leaflet in the way anymore. So for number 3, I think there are techniques you can do for those anatomic subtypes. So Basilica, to me, is a more elegant way to address the problem itself. You could fracture if you want. Use future availability to get into the coronaries for work. As of June, it had been done in almost 50 patients out. Now we're probably over 60. The IDE trial is almost done enrolling. 27 of 30 are already enrolled. And in April of this year, actually, Drs. Khan, Letterman, Babileros, and I actually used this to circularize a bicuspid valve prior to implantation of valve. There was a patient at risk of coronary obstruction and severe eccentricity of the valve. We actually burned through not the raphet itself, but the true leaflet, and then got beautiful symmetric deployment of the TAVR valve with Basilica, a modification of Basilica for bicuspid valves. So that's already been done. Hopefully that will be published soon. So in summary, these are the things that you can do to optimize TAVR in 2008. Make it as least invasive as possible and get these patients home. Make it the most transfemoral-like. Learn some of these techniques to address those certain coronary and other anatomic conditions. And then, actually, I don't know what happened to the slide, but I think balloon valve fracturing during valve and valve TAVR to increase and improve on the patient prosthesis mismatch are all where I think we should be in 2018. Thank you very much.